Why do you think so many people are hesitant to invest in social determinants of health? John Gorman is a former Clinton appointee, Medicare Advantage architect, and the founder of Nightingale Partners, the first venture fund to invest exclusively in social determinants of health. He's helped health plans and investors unlock massive ROI from what many still dismiss as soft care: housing, food, transportation, broadband. This is the conversation that every healthcare strategist, startup founder, and payer executive needs to hear. I'm Christina, and this is Outcomes. Why do you think so many people are hesitant to invest in social determinants of health?
Well, in the world that I come from with health insurance companies and payers, they're mostly just big, dumb bill payers. They never imagined themselves to be social service agencies or social health agencies. They never thought it was part of their job to provide people food or housing or transportation. They just pay claims. And so this is a sea change in how insurance company executives have to think about their job. And that is, if we're at 100% risk for all of the costs of our members, and if paying for social health like food as medicine will save on inpatient expenditures, for instance, then that should now be part of our job. And that's kind of where we are, is trying to get this industry to realize that so much of the costs that we suffer in health insurance are utterly preventable by just providing very cheap social health interventions. And we're still in the process of trying to convince them of doing so.
What are the most convincing arguments that you've seen or made so far that gets financial people on board with making these kinds of investments?
I mean, the return on investment, when you really quantify it for these types of social health interventions, are inarguable. Generally speaking, social health interventions will reliably return a 3 to 8x return on investment net of the cost of the program. But the one example that got me into this whole space, Christina, was I was helping Geisinger years ago. They figured out that they were paying almost dollars per member per year on their uncontrolled elderly diabetics. And they tried everything and they couldn't figure out what to do next. And so I suggested a food as medicine program. And so we did a pilot with 1,000 of their patients. This was back in 2016. And within 14 months, we had the average cost of those patients down to $48,000 per member per year. So net of the cost of the food that we delivered, we saved $192,000 per patient per year on these uncontrolled elderly diabetics. And that was a 35x return on investment. Man, unless you bought Bitcoin back in 2014 and dumped it in 2018, you'll never see a return like that anywhere else. And that's what made me say, I got to be an SDOH investor, because this is where it's at.
I just wanted to ask if you found this video insightful. And if you did, please click on subscribe so that we can continue to ensure no one gets left behind in the value-based future of healthcare. So that's how you sort of segued from just consulting to actually investing capital.
Yeah, absolutely. And that was when I decided I needed to be a venture capitalist and to really put a different spin on VC. So Nightingale was born, and we were the first venture fund to invest in social determinants exclusively. And we did a couple of other things that were kind of unique as part of it. We leveraged in all of our investments the Opportunity Zone program, which came out of Trump's first tax bill. But it was Cory Booker's program that was intended to encourage investment in underserved communities. And when you look at the list of the roughly 9,000 opportunity zones across the country, Christina, they overlap almost 95% with medically underserved areas, according to the federal government. So we knew that these were not just disadvantaged economically, but that these communities were also suffering from a lack of clinical and healthcare resources. And so what the Opportunity Zone program says is that if you invest money in one of those neighborhoods and you leave it in for at least 10 years, then not only is the initial investment completely tax-free, but then all of the proceeds and all the profits that you make on that investment are tax-free. And that is a massive tax shelter to encourage investment in this stuff. So opportunity zones had only really been used for like real estate deals until we came along and we started investing it in stuff like commercial kitchens so that we could prepare meals for delivery the next day, or housing programs for foster kids. We used out in LA one time, and we used the program for gun violence reduction efforts by building little community centers around New Orleans in these at-risk neighborhoods. So the Opportunity Zone program was a different spin on VC for us in this space. And then the other was that I would leverage our relationships with big insurance companies, and we would go to them and say, let us analyze your member data and let us identify the members that you've enrolled that are in need of social health support. And then we would then map out in their service area where those people were and what their needs were. And we would approach community-based organizations in those neighborhoods first to see what their capacity was to serve these people. And where they couldn't meet the need, then I would bring in my portfolio companies that we invested in at Nightingale to meet the rest of the needs. So I was double dipping as an investor a little bit, and then I was investing money in them, but then I was leveraging my relationships with insurers to supercharge the growth of those portfolio companies. And it worked really well for a number of years until we sold it in 2022.
What led you to sell?
Well, my biggest investor, we were going out for our second round of funding, and he said, I could write you another check for 25 million bucks, or you could come here in-house and we'll do this like an acqui-hire, and you'll have access to a $300 million war chest to do these same kind of deals. And that sounded pretty good to me until we got there. And within about 2 weeks, I realized that it was not going to work out. And that happened to be right at the moment when my mother got sick and my daughter started having some trouble. So I took my package and left and agreed to stay on as chairman of the legacy investments, which all but one are doing great right now. So it was a good run while we had it. And I think a good model for investing in early stage companies in the social health space.
Yeah. What are some takeaways that you have for anybody that has an interest in investing in social determinants or starting their own, these health systems that are starting their own initiatives?
Well, one is you got to be data driven, and you have to be able to do really, really actionable intel on where your members are and what their social health needs are. So before we did any projects with these big insurers, Christina, we would look at about 5,000 different sources of publicly available data to see what was going on with their enrolled population. So it goes way beyond what most people do in terms of looking at income and race and ethnicity and things of that sort. We were looking at who checked into a homeless shelter in the last 2 years, who had their home foreclosed on or a car repossessed in the last 2 years, who
Did you
checked
capture
into...
that data?
Well, that's all out there and it's available. You just have to know where to look for it. And luckily, one of my partners, Pam Taylor, was a double PhD in social health architecture and intervention. And Pam knew exactly where to go for this stuff. So one, you need actionable intel on which members need what so that you can plan your interventions in the most effective way. Two is you really have to look for the members that are most impactable. You're not going to be able to help everybody. And even among, say, uncontrolled diabetics, there are going to be a lot of folks that just don't want the help. They're suspicious of their insurer, they're suspicious of the government, as so many people are right now, or whatever their superstitions may be. But people have reasons for not wanting to take help. Sometimes it's extended to them. And so we really always tried to focus on the folks that were most impactable and that we knew, we would be able to successfully engage. And one of the things that was really interesting about that was we found we had very low engagement rates in a lot of these interventions, Christina, especially in rural and inner city communities, when we found that these folks did not have internet access. And so we started making broadband internet available as part of our portfolio. And we found that our participation rate among the patients went up by 300 to 500%. So, for instance, we did this huge diabetes project in California, And we instantly, the second we gave these folks internet access, we quadrupled the number of folks that were participating in the intervention and tripled the number of folks that went all the way through the program to a successful result. So, you really have to be very data driven, and you have to be, I hate to say it, but you really have to kind of hard code empathy into your architecture and your design, because you really have to understand what's motivating people from not participating in programs like this so that you can get them the help that they need on where they live and on their terms. Does that make sense?
Absolutely. I think we're kind of on the same aligned with that idea that people conceptualize these social determinants initiatives as being something that's, morally correct, or using these emotional arguments. And while that's maybe true, what's also true, and I think the larger part of it, is that you're more effective the less emotional that you are about it, and the more that you're, sort of data driven. I do want to latch on to something that you said there about these metrics. How can you be sure that you're capturing the right metrics?
Well, I'm glad you asked that, because we had to, being investor backed, we had to demonstrate, to prove with data that we were actually getting the results that we wanted. So the data sharing between the plan and ourselves was absolutely critical, and frankly took the most time. It took more time to get the data out of the plans than it did for us to stand up these interventions at the community level.
Sure.
We would start first with trying to build our KPIs and our performance metrics around the metrics the plan was already using. So we would try to tie them to HEDIS measures or star ratings measures or Apple ratings in Medicaid, if that was the case first. And, the problems that the challenges that we had were often in states like California, where they had the delegated model, and they would have an at-risk medical group that we would have to collaborate with. And the big problem that we got into was attribution, and to whether or not the results that we were getting were truly attributable to the food that we were delivering, or the rides that we were providing, or the housing that we gave these folks. The medical groups could stick their hand up and say, well, no, we've got this cardiovascular health program that we offered these people too, alongside your food program. And that's what actually got the result, not your food. And so we really did have to be very thoughtful about the data and how to actually attribute results to an intervention. I think it's very important for anybody in this space from Jump Street that you've got to have an actuary engaged, because at the end of the day, if you want to do these kind of projects with payers, it's not a chief medical officer or even a charismatic CEO who's making these decisions. It's the chief actuarial officer who has to sign off on this stuff. So if your interventions, your results don't pass actuarial muster, you're just not going to get paid, and you're not going to get much success in getting repeat engagements with plans like these. So know your numbers, and to be able to tie them to your results beyond a shadow of a doubt where you can.
Can you name any specific example where you learned, that that this specific intervention was tied to a social care project as opposed to a medical intervention?
Yeah, all of them, showed results like that. So for instance, we did a big project in LA right at the outset of the pandemic, where our client had 75,000 foster kids enrolled in their Medicaid plan. And about every month you would have thousands of these kids that would hit age 18 and would become emancipated. And they would then find themselves on the street. Their foster families would put them out because the state wasn't paying them anymore for them. And these kids were 18 years old with no skills, no place to go, no money, nothing to do. And what LA County found was that within 6 months, more than 50% of these kids were either addicted to opioids or being trafficked, or both. So we took a housing first approach with these foster kids, and we went and did a deal with these long stay corporate housing chains like Candlewood Suites and Long Stay America. And we went and got a block of rooms from these guys around LA County, where these foster kids could land in a cordoned off section of their hotel for safety. And we would pay their rent for the whole year and have nurses and community health workers living alongside these kids in this long-term corporate housing. And the results that we got from that intervention were absolutely unbelievable. But we had a lot of these capitated medical groups in LA County that were trying to take care of these kids that were saying, oh, well, we're doing this, we're doing that. We should be sharing in some of these performance-based payments that are resulting from this. And, that's where you get to the difference between causation and correlation, and where you have to be able to try to filter out, again, with the help of an actuary, what actually delivered that result for the payer and for the patient. So you really got to know your data and really have an actuary on the ground floor to help you sort through it all for what's most effective.
Another podcast, you also talked about a similar kind of housing initiative that you did for these dual eligible seniors. Do you remember which case it was?
We did several of those.
Okay. This is a very complex population, as I'm sure you
Very.
know.
Yeah.
What makes this population challenging?
Well, the duals are the most vulnerable people in the entire US health system. I mean, these are folks that, by definition, they get both Medicare and Medicaid. So these are very low income seniors or people who are under 65 and disabled to the point of disability where they can't work. And so these are going to be folks with developmental disorders, with with really serious mental health conditions, and physical disabilities. So the most vulnerable folks that you've got out there, and generally they live in communities that are medically underserved and have the fewest resources to help them with. When we talk about the duals, I like to think about the concept that we have in social health, Christina, called weathering. And that is that when you've lived a lifetime of poverty in healthcare charges interest. And, the older you are and the longer that you've lived in poverty and suffered from the compounding effect of racism your whole life, you generally have much worse health conditions and comorbidities in your later years. And so the duals are almost 2-1. Folks that are experiencing 3 or more healthcare conditions, on average, they're taking 8 or 9 different medications, some of which interact badly with each other. They have the least access to resources, being cash and other support in their community. They often live in the most substandard housing that will often have lots of indoor air and environmental issues like infestations. I mean, I'll tell you, one of the biggest innovations I've seen for the duals in the last 5 years from their health plans has been pest control and doing home modifications for duals so that they can get rid of black mold in the basement, or cockroaches if they've got COPD or they've got asthma. Those are major exacerbators of those conditions. So where you can meet the duals where they are and help them with social supports for their needs. These folks have a computer 1/4 of the time compared to a regular Medicare beneficiary. They rely on public transportation and they don't have a car. So it's a lot harder for them to get to medical appointments, or God forbid they're on dialysis and they've got to get there 4 days a week for dialysis treatment. You can't miss those appointments or your health crumbles. So those are, just the myriad challenges that you're faced with in serving dual eligibles. But there's a reason, Christina, that Medicare Advantage and Medicaid plans are stampeding toward these folks, because generally speaking, if you're good at managing duals, they bring with them double the profit margin of a regular Medicare Advantage beneficiary. So they're very much the focus of the big for-profit nationals right now, especially.
Still, though, as complex as this population are, you have mentioned some really straightforward, kind of simple services, the pest control, the basic housing, the meal delivery. So it kind of goes against that the idea that, you have a complex population. It's either too complex or too expensive to manage or to serve. But yeah, like as I said, it's these really straightforward kind of just covering the basics.
What we found was the linchpin of all of our interventions for the duals, Christina. The common thread among all of the projects that we did for this population was a community health worker, and assigning duals an advocate, somebody who knew how to navigate the health system, somebody who knew how to arrange all the social services that they needed. And, we have to remember that duals have the lowest level of health literacy of anybody in the health system. And so they just needed basic help in figuring out, how do I arrange a visit with a cardiologist? How do I follow up on this guidance from my primary care physician on how to manage my diabetes and my COPD better? How do I arrange transportation to get to dialysis 4 days a week reliably? And we found that a community health worker was the absolute key to unlocking those services and to arranging the help that these folks needed. The system is just too complicated, and there are just so many barriers for the duals in this system that everybody needs an advocate, but especially dual eligibles do. And somebody who can clear the rocks from the road in this crazy complicated health system of ours so that they can get the help that they need.
As a 10-year-long social worker that got my start out in the community doing home health and hospice.
So you know what I'm talking about, yeah.
With these dual eligible population, could not agree more. I've spent many a long hour just in these homes applying for benefits, applying for long-term care.
Yeah. Exactly.
Just digging up and finding those documents, or just making an appointment.
They need helpers. And, when you realize that something as cheap as a community health worker can help reduce the expenditures of duals reliably. Like we found, reliably, the assignment of a community health worker would result in as much as $2,500, remember, per year in reduced costs for a dual net. So having paid for the CHW at least $2,500 cheaper just to have somebody arrange this stuff for them was well worth the investment on our part.
So that's another part of my question is, when we talk about the impact of a community health worker, of social workers like myself, is it only because the salaries are not what you would pay like a doctor or a nurse?
Yeah, I mean, doctors don't have time to be arranging social health services for these people.
They try though.
I come from a whole family of doctors, and most of them are in primary care, and they see 40 to 60 patients a day. Nobody has time in a busy doctor's office to arrange rides or meal delivery or housing supports for these people. So it has to be an allied health professional, ideally embedded in these doctors' offices, or that who go to all these appointments with the patient so that they can see all this stuff through. There's just a lot of folks out there that want to just be able to keep responsibilities on doctors, and they don't have the time to do this kind of stuff. So we have to recognize that the best path is to just provide these resources for them. And what's interesting is that as the years went by on these interventions that we did, Christina, we found the burnout rate of the primary care physicians that we were collaborating with went way, way down when they knew that there was a community health worker or other social support in place for these patients, because there wasn't as much pressure on them during those visits, and they knew that they were getting the non-clinical services that they needed to get better care. And so that was a really unexpected benefit of some of this stuff, was seeing the attitude and the burnout rates of affiliated docs and nurses go way up, because they knew that these folks were getting the services they had always been aware they needed.
I think the moral injury of not being able to truly meaningfully help patients is something that's just not talked about enough.
It weighs very heavily on them. And I love that phrase, moral injury, because that is the biggest contributor to physician burnout.
But overall, you're not saying that we need to pay social workers less.
No, not at all.
To make a return.
The reason I love community health workers, Christina, is that, whenever we went out and did mass recruiting and hiring of community health workers, you're hiring for a personality type. And so very often the folks that we hired as community health workers were just these really lovely church ladies who are doing this stuff anyway as just part of their mission to their community. But then we came along and offered them a job at $30 an hour to do what they were already doing, and they loved it. And these are the helpers that live in every one of these underserved communities. They've lived there their whole lives. They have the same lived experience as these patients. And so it was part of our effort to inject some economic development into these communities by creating jobs where they didn't exist before. So when we went in and hired 100 or 300 community health workers in South Central Los Angeles, we would typically go to churches on Sunday and we'd set up a stand out in the parking lot and say, we're hiring. And people would line up around the block because this was their personality type. They were the big souls, the good Christians that really wanted to be doing this. And if we're going to pay them, and then give them resources like integrated iPads that they would take on their visits to manage their caseload and to help them arrange these services digitally while they were there with the patient. I mean, they loved it. And most of those folks are still working in those jobs today, years later.
You mentioned before on other platforms, I believe, and you didn't say the word dignity, but I'm just going to, I understand it as dignity, but there is a level of human dignity that needs to be in place for these interventions to be successful. So one of the examples that you've given, what I'm talking about is when you said that there was these meals that your mom was getting and that they were nasty and nobody wanted them and they give away. So can you tell me more about that? What is it? It's not just any kind of service, right? It's got to be a certain kind of like nuance that's put into it, or like I say, going back to the dignity thing.
I mean, an intervention is only as good as the quality of what it is that you're providing. Okay. So if you're trying to do a food intervention for people who are hungry, or food as medicine for folks that have metabolic conditions like diabetes, you can't expect people to eat shit food if that's what you're providing them. And so dignity has to factor into everything. And from where we sit, dignity just doesn't include, say, the quality of food, but it also is dependent on the cultural competency of what it is that you're doing. For instance, you don't want to provide Jamaican food to Ukrainian seniors. You want to be thoughtful about and empathetic about what it is that these folks want, what they need, what they expect. You have to recognize that there are stigma associated with social health and social supports. I mean, there are millions of dual eligibles in this country who are eligible for Medicaid, but will not enroll, Christina, because of the stigma associated with being poor and being enrolled in Medicaid. And I deal with that every day. Wednesdays, I go and do enrollment sessions for seniors here in DC that are aging into Medicare to help them make coverage decisions. And,
Wow.
I bring interpreters with me because my Spanish is good, but not great. But we have a lot of other languages here in DC that folks need. And so I'll bring interpreters. And, when you're doing things like food, you have to understand what their preferences are if you actually want them to eat it. When you're doing transportation, you have to tailor the ride to the needs of the member. You can't expect a 100-pound little Ethiopian guy driving for Uber to go get Big Mama from a 4-story walk up for dialysis 4 days a week. That little Ethiopian driver is going to need 3 helpers and a special vehicle to get Big Mama over to dialysis. So you just can't have, untailored or unspecific solutions for these members. When they're complex, that means that the solution needs to be complex and it needs to be nuanced and empathetic in how it's delivered. So dignity is huge and it's a catch-all, but I think it really needs to include things like cultural competency, and just some general sensitivity to the circumstances in which these people live. And if people want to call that woke, then I'm woke, but this is what works in our experience. And you have to meet these people where they are, and with some dignity about the circumstances that they're in.
Are there any types of social determinants of health initiatives that you've seen rolled out or that you've experienced that are just kind of overrated?
Well, interventions that are not specifically tailored to specific populations and to specific members. I mean, I think a lot of the reason plans don't succeed with these types of benefits are a couple of things, Christina. One is a lot of the plans are still locked into thinking that these kinds of social health benefits are really only useful for marketing and retention. And that's a shitty way of thinking about this stuff. that we're going to induce members in with, say, a food benefit or a transportation benefit, and they'll stay with us because of those benefits. And that may be true, but it's discounting or ignoring the fact that these interventions are actually clinical weapons, and that, used right, can really reduce expenditures to the point where they pay for themselves several times over. So what doesn't work is untargeted interventions and carpet bombing these kinds of benefits over a population rather than rifle shots on the folks who really need them the most. Two would be not applying the right lens of cultural sensitivity and competency to what you're doing. You can't go into, say, a Haitian community and try to use an intervention that may have worked with a Filipino population. You got to meet them where they are with the language that they're familiar with, say, food that appeals to them, or drivers that will be able to meet their needs and understand that there isn't an elevator in this building. I'm going to need help getting down 6 flights of stairs to go to this appointment. So it really, the more you know about these members, the more successful the intervention will be. And just, like throwing gym memberships at people, I just think is just kind of dumb. That's a benefit that's going to appeal to the worried well. That's going to go to Leisure Suit Larry, who's 65, just aged into Medicare. He's very healthy. He plays golf 4 days a week and pops Viagra a couple times a week. That's a healthy guy. He's not really in need of a lot of social health intervention. A gym membership is going to appeal to him, right? Or silver sneakers. But that's not a guy who you want to drop a housing benefit or a food benefit on, because he just doesn't need it, and it's going to reduce the effectiveness of your intervention overall by including people like Leisure Suit Larry in that intervention.
And then also to that, on the other side of that same gym membership is going to mean something very different to somebody that doesn't, that's lived a lifetime of poverty, because that's access to a shower, that's access to air conditioning, and, shelter from the elements, at least for some time. That's access to community.
Exactly. There are a lot of ways to screw this up, and a lot of plans throw money at this stuff and don't get the result. And then they just kind of lose faith in this whole approach of providing social health benefits. But when you're thoughtful about it and you're data driven and you're looking at how do we target this to impactable populations, that's when you start getting the results that you can't ignore and that ultimately pay for these benefits themselves many times over.
Well, you said before that you said something along the lines of you need to address these social determinants of health in a very scalable way. You have to kind of go all in. So is there a balance or a kind of like framework that you figured out as far as like being targeted and being data driven and being deeply aligned with the population, but still being scalable?
Yeah. And scalability is really a function of what that intervention is. Scalability is very, very different when you're talking about, say, housing than you may be when you're talking about food or, say, transportation. So like housing, for instance, is really tough because now you're dealing with zoning and coding and, YIMBY politics and people not wanting to, say, have affordable housing in their community or long-term housing for the homeless in their community because they think it'll impact their property values. So housing interventions at scale, Christina, can take years to get off the ground. So that's why, I invested in companies like Upside, which maintain a network of readily available housing units for seniors in particular, where they can get somebody into safe housing within, say, 48 hours anywhere in the continental US. That's critically important. When you're doing this stuff at scale, though, where you're starting to talk about group houses, or you're talking about converting derelict hotels or motels into subsidized housing for your members, that stuff can take years and can be really a lot more difficult to manage over the long haul. Food is really a function of how many people, how many meals per day, what are their metabolic needs? So how many calories do they need per day? What are their food restrictions if they have diabetes, if they have kidney disease, if they have IBS, if they have Crohn's, and being able to design a menu that will speak to not just their metabolic disorders, but then also to their culture and what food they're going to find attractive, and then to be able to provide that at scale. So, where we're doing this for, say, a few dozen people, we may be able to partner with Meals on Wheels or, a little church group where you've got 10 church ladies that are putting 200 meals for delivery the next day together in the church basement. Well, now let's say we're going out to that community and we need 5,000 meals a day, most of which are tailored to specific metabolic conditions. That means we're going to need a commercial kitchen and not just whatever the church ladies are producing in the basement. We need a real kitchen with more employees, volunteers, etc., to be able to meet that need. And so we would go and build those kitchens and then provide all the supply chain that would be necessary to do that at scale. It was really what we set out to do with Nightingale, Christina, when I was seeing what was going on with social health referral platforms like Unite Us or Aunt Bertha. Those are great referral platforms, but they're doing nothing to increase the capacity of social service organizations to meet a greater need. So a lot of those referrals would just get lost in the ether when the local area agency on aging would say, we're not taking any more patients, we're at capacity. And those folks don't get their needs met. We said, let's first go out and assess the needs of the population, assume what they're going to need at scale, assess whether or not the local community organizations can meet that need on their own. And if not, what additional capacity do we have to build to meet that demand? And that's kind of where we ended up, and why we would invest in things like commercial kitchens or little housing hubs. For some of our members, we invested in adult daycare centers in some of these communities. So these frail seniors would have a place to go during the day where they were safe and where they could get their meals, 2 meals a day, and they could get their physical therapy and they could have some social interaction. So it's all about the data. It's all about really understanding the needs of that population and charting your intervention, designing your intervention to meet those needs.
Well, part of our audience here is some of those social care startups and organizations. We obviously want to give them all of the information and support that they need to be successful. So going off of, just to branch off of what you just said, it sounds like you had sort of a rigorous test of which organizations kind of meet specific criteria and that for investment. How did you determine which ones to invest in, other than what you just said, as far as like your population needs? What are some of the other things that you looked at?
Again, it gets back to the impactability of specific populations, Christina, and what we can provide when that would get the best and most sustainable result. So for instance, we were doing a project in Oregon a couple of years ago. And as we started running the data for this plan, we just kind of assumed we were going to find all the usual stuff, 40% rate of diabetes and folks that were going hungry, folks that weren't getting good, healthy food to help them manage their condition. And instead, the data came back and said the most impactful thing that we could do for that population was home modifications. And we were like, wow, because housing costs in this part of Oregon were so astronomical. These seniors were spending 50 to 60% of their available income on housing. And so they couldn't maintain their properties. And a lot of these homes were falling apart. And these folks were tripping and falling and breaking hips and ending up in the ER at $60,000 to $100,000 per admission. That was happening.
So you're talking about like beyond the guardrails and the ramps, like
yeah, like these folks had loose boards, they had holes in the floor, they had, stairs that were crumbling. And then, because it's also a huge contributor to falls, we found a lot of these folks, when we analyzed the drugs that they were taking, were interacting, and it was making them loopy, and they were falling a lot. So it wasn't even necessarily the quality of their housing stock, but they were taking benzos or lorazepam that was making them loopy, and they were falling a lot. So we not only had handymen going through and fixing loose boards and railings and stuff like that and putting up bumpers, but we had pharmacy assistants that were going through all of their medicine cabinets to say, what's making you fall?
Awesome.
more than your neighbors are. And that was a fascinating project for us because that result was huge and it was almost immediate. We saw the number of falls resulting in hospitalizations absolutely plummet after this initiative. And it was just a real eye opener for us that we should never assume what the problems are going to be when we go into a community. Let the data tell you where the needs are.
One last question. What's the most amount of money that you've made or that you've helped your partner make from a social care innovation?
Wow. What a cool question. I've never gotten that before. Well, certainly it depends on the lens you want to look through, Christina, right? In terms of the length of time to generate a specific result. So for instance, food typically can generate the fastest returns. Like for instance, on the Geisinger project, that was 14 months when we started seeing these inarguable results on what food as medicine can do for diabetes. If you look out a little longer horizon, you typically get better results and better returns from housing over the long haul than you do from everything else. But again, housing can be months or years before the intervention is stood up. Like in Los Angeles, there's just not a lot of available housing that's out there unless you're going to long-term corporate housing chains that have lots of empty rooms because of the pandemic and its after effects. So, we were innovative enough to be able to go to struggling long-term housing chains to say, you have immediate stock available. We have immediate need. Let us put 1,000 kids into your facility next week. When you have to build housing or modify housing, that takes a lot longer. But over the long term, housing typically generates the biggest return on investment over time. Food, the shortest and the most impactful. And let me just say, with Trump and DOGE slashing and burning every federal program here in DC right now, and it is chaos. And these guys succeed in this budget resolution in eliminating programs like Meals on Wheels, which right now is on the chopping block and will end this year with the cuts that are envisioned. It's going to fall on health plans to start providing the social safety net that other federal programs have been doing historically, and that this administration is going to burn to the ground. And so the plans really need to start preparing now to plug the holes in the social safety net that are going to be created by the budget cuts needed for Trump to get his next billionaire tax cut. And so plans need to be ready now, and none of them are.
So, in that sense, these governments kind of like offloading a lot of their risk onto the healthcare industry
Yep.
as
And to
opposed
states. Yep.
and
And the
just as
state
opposed to like
budgets.
other countries that provide the social safety net that is
Exactly.
able to that's kind of like this invisible infrastructure for,
Yes.
their healthcare programs.
You're exactly right. When we have a social safety net that's shut full of holes like Swiss cheese, it always ends up falling on the health plan because we're at 100% risk for the cost of these folks. So the more that plans, especially these days when that social safety net is getting shredded, the plans really need to step into the breach here, the gap that's being created by federal programs that are getting slashed and burned, and where state budgets, especially in red states that don't have income tax or property tax to provide basic infrastructure and social health programs like this, it's going to fall to the plans as the last resort.
That is a great mic drop to end this on.
Yeah. Yeah. It's going to be very scary, I think, for a lot of folks in the insurance industry in this next 4 years, Christina, because they are going to get hit in the head with a baseball bat that you are now the social health agency for your members. You're not just paying their claims. You're not just arranging their clinical services. Now it's going to fall to you, if you're smart, to start arranging their social health services as well.
Well, that means like all the more coming from you because your OG Medicare Advantage plan, you've been there since the
Yeah.
inception. So
Yeah.
just given everything that you've seen so far with the evolution of Medicare Advantage, what's a final note that you can leave for anybody in that space?
I think there's an enormous opportunity here for forward-looking plans to start putting platforms of these social services together in their own service areas in their communities. And the ones that get the first jump out on this stuff, I think will be able to sell these services to other health plans in their communities. There are companies like Highmark and UPMC in Pittsburgh that are already jumping out and developing social health platforms. Care First in Maryland's another one where they are investing in these types of early stage companies in the social health space, creating a marketplace of these types of services in greater Pittsburgh or in Northwest Pennsylvania, for instance. And they could make those services available to other plans like Geisinger or Kaiser that are also competing with to provide these services in a more cost-effective way. There is definitely the law of numbers here, and scale works. And I think this could be an interesting place where plans rise above competition with each other and start building solutions in collaboration that are more cost effective when they do it all together as one. It'd be interesting.
So,
Because we just can't rely on the federal government anymore when Twitler and his little Doge dogs get done slashing and burning what's left of the federal government.
yeah, ironic that in a political environment that's kind of been very corrosive to social care benefits, that's actually what leads to the most amount of ROI for, like, at least potential for ROI for our healthcare organizations now.
I mean, this is a full-blown war on the poor that this
Yes.
administration is waging right now. I mean, nuking USAID, destroying agencies within HHS that fund things like Meals on Wheels or community health centers or community-based drug treatment programs. Those are all going away. And so the need for plans to morph into social health agencies as well as clinical organizers of care, that day has arrived, and the plans need to evolve or die. It's just that simple.
Evolve or die. Love it. Thank you so much for
My pleasure,
all
Christina.
of
Thank
this.
you. This is a
So
really great conversation. And you asked questions that I've never gotten before, and that's always refreshing. And I appreciate that. Thanks so much. You're so thoughtful about this stuff.
thank you. We do
Comes from
things
the
a little
social
different
worker
here.
in you, I guess.
That's right.
Some of my favorite people.
Appreciate you. Where
Thank
can
you,
they
Chris.
find you?
Well, you can find me on LinkedIn. I'm there a lot. I'm active there. And then I'm doing a lot of board work, a lot of strategic advisory, but you can always reach me on LinkedIn, and I'm there every day. So find me there if you like.
Gotcha. All right. Thanks so much.
Thank you, Christina.
Bye.